Yesterday, the American College of Cardiology and American Heart Association published the 2025 Guideline for the Management of Adults with Congenital Heart Disease. The prevalence of adult congenital heart disease is increasing. There are now more adults living with congenital heart disease than children, so it is especially important to keep up with the standard of care in managing these complex disorders. What do you need to know? The document is packed with valuable information spanning over 100 pages, excluding references. So I want to break it down for you and highlight the most important changes you need to know about for your practice or your training. The 2025 Congenital Guideline updates and replaces the 2018 ACC/AHA Guideline for the Management of Adults with Congenital Heart Disease, which I will be referring to as the 2018 Congenital Guideline. I'm going to do a deep dive on 6 major update areas: pregnancy and delivery, atrial septal defect closure, Fontan screening, pulmonary valve replacement and tetralogy of Fallot, Eisenmenger syndrome, and management of cyanosis, and also 4 minor update areas: heart failure, GDMT, and congenital disease, sports participation, rhythm control, and personnel and expertise. We will start with pregnancy and delivery. The 2018 guideline had no specific recommendation about the mode of delivery for pregnant patients with adult congenital heart disease. The 2025 guideline now includes a strong recommendation against routine cesarean delivery. Specifically, it states routine cesarean delivery has no benefit and may cause harm in pregnant patients with ACHD in the absence of an obstetric indication or high-risk cardiac condition. Class 3, no benefit. Several congenital heart disease conditions are associated with significantly higher risk for maternal complications, such as severe symptomatic left-sided obstructive lesions, severe native coarctation or recoarctation, cyanotic congenital heart disease or Eisenmenger syndrome, Fontan physiology, and systemic right ventricle with at least moderately depressed ventricular function. However, even in many of these high-risk scenarios, vaginal delivery with appropriate monitoring and multidisciplinary cardio-obstetrics team support is often feasible and preferred over cesarean delivery, which carries its own set of risks. Cesarean delivery should be reserved for obstetric indications or specific high-risk cardiac conditions where the hemodynamic stress of labor would be particularly detrimental. It should not be performed routinely just because a patient has congenital heart disease. Of course, a multidisciplinary cardio-obstetrics team should care for most patients with ACHD during pregnancy with individualized risk stratification using the modified WHO system or the CAP-REG score. Not surprisingly, the 2025 guideline also says, for patients with ACHD who are considering assisted reproductive technology, discussions involving an ACHD cardiologist can be beneficial to increase patients' knowledge about their options and the associated risks. Let's move on from pregnancy to ASD closure. The 2025 guideline has significantly expanded and refined the criteria for ASD closure, particularly in patients with pulmonary arterial hypertension. This is one of the most substantial updates in the guideline. Let's start with the straightforward cases. For patients without pulmonary arterial hypertension, the recommendation is similar to before but with clearer language. The 2018 guideline had stated, in adults with isolated secundum ASD causing impaired functional capacity, right atrial and/or RV enlargement, and net left to right shunt sufficiently large to cause physiologic sequelae such as pulmonary systemic blood flow ratio QPQS of 1.5 to 1 or more, without cyanosis at rest or during exercise, transcatheter or surgical closure to reduce RV volume and improve exercise tolerance is recommended, provided that systolic PA pressure is less than 50% of systolic systemic pressure and pulmonary vascular resistance is less than 1/3 of the systemic vascular resistance. The 2025 guideline simplifies and clarifies this. In adults with unrepaired ASD, significant left to right shunt with QPQS of 1.5 or more and RV dilation, in the absence of pulmonary arterial hypertension defined as PVR of less than 2 Wood units inclusive, or significant LV disease, ASD closure is recommended to improve functional class and clinical outcomes. First, Impaired functional capacity has been removed from this class 1 recommendation. You no longer need to demonstrate impaired functional capacity to recommend closure if the patient has a significant shunt and RV dilation without PAH. Second, the threshold for what constitutes no PAH has been simplified to PVR of 2 or less Wood units. The 2018 guideline used a more complicated criteria we are familiar with, the systolic PA pressure less than 50% of systemic and PVR less than 1/3 systemic resistance. But now it's just PVR of 2 or less Wood units. The 2025 guideline introduces an entirely new set of recommendations for patients with mild to moderate pulmonary hypertension. The 2018 guideline had a weak Class 2B recommendation that stated percutaneous or surgical closure may be considered for adults with ASD when net left-to-right shunt is 1.5 to 1 or greater, peak systolic pressure is 50% or more of systolic arterial pressure, and PVR is greater than 1/3 of the systemic resistance. The 2025 guideline now provides more specific guidance with 2 new recommendations. First, in adults with an unrepaired ASD, significant left-to-right shunt of QPQS of 1.5 or more, and RV dilation with a pulmonary vascular resistance of more than 2 but less than 5 Wood units, and without significant LV disease, ASD closure is reasonable to improve functional status. That's a Class 2A recommendation. So now for patients with mild PAH as PVR of 2 to 5 Wood units, ASD closure is reasonable. Class 2A upgraded from Class 2B. Second, in adults with unrepaired ASD, significant left-to-right shunt, meaning QPQS of 1.5 or more, RV dilation, and PAH, that's more substantial, PVR of 5 to 8 Wood units, and without significant LV disease, closure can be beneficial if PVR less than 5 Wood units can be achieved using targeted PAH therapy to improve medium-term functional status. So, even in patients with moderate PAH defined as PVR of 5 to 8 Wood units initially, if you can get their PVR down to below 5 Wood units using PAH-directed medical therapy, then ASD closure becomes reasonable. We're now actively treating PAH with medications in select patients to get them to a point where you can do the ASD closure. Of note, in adults with an unrepaired ASD and PH for whom closure is indicated, fenestrated repair can be considered to improve functional class and clinical outcomes. A fenestrated repair refers to leaving a small controlled communication between the atrial after closing the ASD. This allows for a pop-off mechanism if right-sided pressures become too high after a closure, potentially reducing the risk of acute right heart failure while still providing some of the benefits of reducing the shunts. Be mindful of the limits. The recommendation for closure with Eisenmenger physiology remains unchanged. It says, in adults with an unrepaired ASD and Eisenmenger physiology, ASD closure should not be performed to avoid increasing morbidity and mortality, Class 3 harm. As we know, Eisenmenger physiology represents irreversible PAH where the right to left shunting is fixed, and closure would thus be harmful. The guideline also includes new recommendations for specific types of ASDs. For premium ASDs, sinus venosus defects, and coronary sinus defects, the 2018 guideline had a Class 1 recommendation for surgical repair under similar criteria as secondum ASDs. The 2025 guideline adds a new option. In adults with unrepaired superior sinus venosus ASD, transcatheter closure, when technically feasible, may be a reasonable alternative to surgery to reduce operative morbidity. Class 2B recommendation. The guideline also adds a new indication for ASD closure that was not explicitly stated in 2018. In adults with an unrepaired ASD and evidence or strong suspicion for paradoxical embolism, ASD closure is recommended to prevent recurrent embolism, Class 1 recommendation. Regarding the method of closure for isolated secondum ASDs, both guidelines agree, but the 2025 guideline states it even more clearly. In adults with an isolated, unrepaired secondum ASD, transcatheter closure is usually preferred to surgical repair to reduce the length of stay and recovery time. That's a Class 1 recommendation. So to summarize the ASD changes, of which there were many, the 2025 guideline provides clearer thresholds for closure decisions, expands the indications for closure to include carefully selected patients with mild to moderate PAH, introduces the concept of PAH treatment with medications followed by closure once the PVR comes below 5, and recognizes fenestrated closure as an option. That covers the updates regarding ASD closure. The third major update relates to surveillance of adults with Fontan circulation. As we know, the Fontan procedure creates a circulation where systemic venous return is directed passively to the pulmonary arteries, bypassing the heart. It's a palliative surgery for single ventricle physiology, and while life-saving, it's associated with numerous long-term complications affecting multiple organ systems. Fontan-associated liver disease is recognized as a nearly universal complication in long-term Fontan survivors due to chronic elevation in central venous pressure. Studies have shown that hepatocellular carcinoma in Fontan patients can occur at a younger age and without the typical cirrhotic background seen in other populations. The 2018 guideline had a Class 2A recommendation that stated, imaging of the liver and laboratory evaluation of liver function for fibrosis, cirrhosis, and/or ACC are reasonable in adults after Fontan palliation, Class 2A. The 2025 guideline has significantly strengthened and specified this. In adults with Fontan circulation, imaging and laboratory evaluation of the liver should be performed at least annually to screen for hepatocellular carcinoma and for evidence of progressive Fontan-associated liver disease, Class 1. Note few key differences. First, the class of recommendation has been upgraded from 2A to 1, from reasonable to recommended, and the frequency is now explicitly stated as at least annually. The surveillance doesn't stop at the liver. The 2018 guideline also had a Class 2A recommendation that stated in adults after Fontan palliation, it is reasonable to perform biochemical and hematological testing on an annual basis, especially for liver and renal function. The 2025 guideline has upgraded that from 2A to 1 and broadened this to recognize that Fontan physiology can affect multiple organ systems, even beyond the liver and kidney. So it says, in adults with Fontan circulation, annual laboratory evaluation is recommended to assess for evidence of organ system dysfunction or hematologic abnormality. Unsurprisingly, it recommends cross-disciplinary collaboration. In adults with Fontan circulation, consultation by a hepatologist in collaboration with an ACHD cardiologist is reasonable to facilitate interpretation of hepatic testing, diagnose and treat complications related to portal hypertension, and participate in timing and management decisions specific to organ transplantation. That's a Class 2A recommendation. This is a new recommendation that was not in the 2018 guideline. The guideline's central illustration highlights these three components of the Fontan liver surveillance: hepatic screening with imaging at least yearly, Class 1 recommendation; serologic evaluation of hepatic function, including alpha-fetoprotein levels at least yearly, Class 1 recommendation; and consultation between a hepatologist and an ACHD expert, Class 2A recommendation. The 2025 guideline also includes several new Class 1 recommendations related to detecting and managing complications in Fontan patients. In adults with Fontan circulation and new onset or worsening atrial tachyarrhythmias, evaluation with imaging and follow-up cardiac catheterization as indicated is recommended to assess for potential contributory anatomic or hemodynamic abnormalities and Fontan pathway thrombosis. In adults with Fontan circulation and new or progressive symptoms, hypoxemia, declining functional status, or evidence of progressive or new onset non-cardiac organ dysfunction, hemodynamic evaluation with cardiac catheterization is recommended to guide therapy. That was Class 1 recommendation for both this one as well as the last one. In adults with Fontan circulation and newly progressive or severe hypoxemia or hypotension, evaluation with advanced cardiac imaging is recommended to rule out thrombus or emboli in the Fontan or pulmonary vasculature, also a Class 1 recommendation. Since Fontan patients can deteriorate relatively acutely, new arrhythmias, declining functional status, hypoxemia, or signs of organ dysfunction should all trigger prompt and thorough evaluation, including consideration of cardiac catheterization and advanced imaging. Now that we've covered Fontan screening, we will turn to the fourth key update area, pulmonary valve replacements in tetralogy of Fallot. For symptomatic patients, the recommendation is straightforward. In symptomatic adults with repaired tetralogy of Fallot and moderate or greater pulmonary valve dysfunction, pulmonary valve replacement, surgical or transcatheter, is recommended for relief of symptoms. That is a Class 1 recommendation. This represents an upgrade from the 2A recommendation in the 2018 guidelines, but the wording is pretty much the same. For asymptomatic patients, the 2025 guideline states, in asymptomatic adults with repaired tetralogy of Fallot, moderate or greater pulmonary valve dysfunction, and at least two of the following: RV end-systolic volume index greater than 80 millimeters per meter square, RV end-diastolic volume greater or equal to 2 of the LV end-diastolic volume, RV ejection fraction of 46% or less, LV ejection fraction of 50% or less, or progressive decline in exercise capacity, pulmonary valve replacement, surgical or transcatheter, is reasonable for improving outcomes, including lowering risk for ventricular arrhythmias and death. That's a Class 1 recommendation. Previously, the 2018 guideline had recommended pulmonary valve replacement, surgical or percutaneous, is reasonable for preservation of ventricular size and function in asymptomatic patients with repaired TOF and ventricular enlargement or dysfunction and moderate or greater PR. While they had it outside of the explicit recommendation statement itself, the supporting text stated that they defined severe RV dilation as RV end-diastolic volume index of 160 milliliters per meter square, or RV end-systolic volume index of at least 80 milliliters per meter square, or RV end-diastolic volume greater or equal to 2 times LV end-diastolic volume. So there's several things to understand here. The increasing use of cardiac MRI imaging in long-term follow-up for patients with repaired tetralogy of Fallot has provided good quantification of ventricular size, function, and pulmonary regurgitation. Recent studies have suggested that RV end-systolic volume index is a better predictor of outcomes after pulmonary valve replacement compared to end-diastolic volume. The guideline notes that pulmonary valve replacement performed prior to reaching specific ventricular size thresholds is associated with normalization of RV volumes, and the use of end-systolic volume as a metric reflects better data on which RV size parameter best predicts post-intervention outcomes. Notice that the 2018 guideline listed RV end-diastolic volume index of 160 or more as the first metric for severe RV dilation, whereas the 2025 guideline now lists the RV end-systolic volume index greater than 80 milliliters per meter square as the primary volumetric criterion. Additionally, the 2025 guideline has added specific ejection fraction thresholds, RVEF of 46% or less and LVEF of 50% or less, as criteria that were not explicitly quantified in the 2018 guideline. The next key update area, treatment of Eisenmenger syndrome, is quite extensive. Let me start with the changes to pulmonary arterial hypertension directed therapy. The 2018 guideline had drug-specific recommendations. It stated, Fontan is a reasonable therapy to treat symptomatic adults with Eisenmenger syndrome with one of the following: shunts other than ASD or VSD, such as PDA or aortopulmonary window, or complex congenital heart lesions or Down syndrome. It is reasonable to use phosphodiesterase type 5 inhibitors, such as sildenafil or tadalafil, to treat symptomatic adults with Eisenmenger syndrome with ASD, VSD, or great artery shunt. Both of those were 2A in the old guideline. The 2025 guideline has consolidated and strengthened these recommendations into a unified drug class agnostic statement. For initial therapy, the 2025 guideline states, in adults with Eisenmenger syndrome and an LV ejection fraction more than 40% who are symptomatic or have reduced exercise capacity, initial monotherapy with PAH-directed therapy is recommended to improve symptoms, hemodynamics, and overall survival. Class 1 recommendation. This new recommendation no longer distinguishes between Fontan and PDE5 inhibitors or between ASD, VSD, and other defect types. Instead, it provides a unified Class 1 recommendation for PAH-directed therapy in this population. Importantly, the 2025 guideline recommendation also adds the stipulation that treatment is recommended for patients with an LVEF of more than 40%, which was not explicitly stated before. The guideline explains that special considerations unique to Eisenmenger syndrome include maintaining a fine balance between the systemic and pulmonary vascular resistance to avoid worsening hypoxia and avoidance of volume overload in patients with functional univentricular hearts. For combination therapy, the 2025 guideline states in adults with Eisenmenger syndrome and an LV ejection fraction more than 40% who remain symptomatic or have worsening exercise capacity on a single PAH therapy, dual combination therapy with an endothelin receptor antagonist and a phosphodiesterase 5 inhibitor is recommended to improve symptoms, hemodynamics, and overall survival. That's a class 1 recommendation. This is also an upgrade from the old class 2A. There is an entirely new class 3 harm recommendation in 2025 guideline. Adults with Eisenmenger syndrome should be advised against pregnancy to decrease the risk associated with excess maternal morbidity and mortality. The 2018 guideline did not have a specific graded recommendation about pregnancy in Eisenmenger syndrome, though it discussed the risks in the supportive text. Why is this a concern? Hemodynamic changes associated with pregnancy may lead to increased right-to-left shunting, worsening RV dysfunction and hypoxemia, small for gestational age births, spontaneous miscarriages, especially in the first trimester, PAH crises in the early postpartum era, and increased risk for thromboembolic events and paradoxical embolism. Pregnancy carries very high risk in women with Eisenmenger syndrome, classified in the highest risk group, WHO Class 4, for maternal and fetal morbidity and mortality. Maternal mortality risk in patients with Eisenmenger syndrome is reported at 30 to 50%, with heart failure exacerbation rates up to 50% and a rate of perinatal fetal loss or morbidity of about 30%. Patients who choose to proceed with pregnancy should be closely monitored during the entire pregnancy by a multidisciplinary cardio-obstetric team of experts in maternal fetal medicine, ACHD, pulmonary hypertension, and obstetric anesthesia. This is another new Class 1 recommendation. The 2025 guideline states, in adults with Eisenmenger syndrome who present with atrial arrhythmias, prompt restoration and maintenance of sinus rhythm is recommended to avoid hemodynamic deterioration. Class 1. The 2018 guideline had no specific recommendation about this. What's the rationale? Arrhythmias are a major cause of morbidity and mortality in adults with Eisenmenger syndrome due to disruption of the delicately balanced hemodynamic and shunt status, with rapid deterioration of the subpulmonic ventricular function and high risk for systemic embolization. The 2025 guideline includes a new Class 2A recommendation. In adults with Eisenmenger syndrome, a regular exercise program in combination with directed PAH therapy can be effective in improving exercise capacity. This was not addressed in the 2018 guideline. What's the evidence? Supervised or carefully prescribed mild to moderate intensity exercise appears to be safe in adults with Eisenmenger syndrome. One small retrospective study that included 20 patients with PAH, of whom 10 had Eisenmenger syndrome, showed that 3 weeks of an in-hospital-based training program followed by 15 weeks of home training were associated with greater 6-minute walk distance, higher peak oxygen consumption, maximum workload, and quality of life, although there was no change in WHO functional class. In a subgroup analysis of adults with congenital heart disease and PAH, those with Eisenmenger syndrome randomized to a home-based exercise training program showed improved 6-minute walk distance compared with patients who did not receive this training. Patients with Eisenmenger syndrome should generally avoid very strenuous activity, competitive sports, and extreme isometric exercise. But supervised structured exercise programs can be beneficial when combined with optimal PAH-directed medical therapy. The 2025 guideline includes 2 related but distinct recommendations about anticoagulation. First, there is a Class 3 no benefit recommendation. Adults with Eisenmenger syndrome should not be routinely prescribed oral anticoagulation given the high bleeding risk and lack of long-term survival benefit. Class 3 no benefit. However, the guideline also adds a Class 2B recommendation. In adults with Eisenmenger syndrome, anticoagulation therapy may be considered for patients with high-risk features such as atrial arrhythmia, new or enlarging pulmonary arterial thrombosis, or prior thromboembolic event, and low bleeding risk to prevent thromboembolic complications. The 2018 guidelines had no specific recommendations on anticoagulation in Eisenmenger. What's the rationale behind this? Thrombosis is common in patients with Eisenmenger syndrome and may occur in a setting of grossly dilated pulmonary arteries, dilated and/or dysfunctional cardiac chambers, atrial arrhythmia, and in relation to intracardiac prosthetic or foreign materials such as pacemaker leads. One observational study reported a very high prevalence, up to 30%, of laminated in situ thrombi in aneurysmal, partially calcified pulmonary arteries of adults with Eisenmenger syndrome. Cerebrovascular events are also not uncommon, affecting about 8 to 14% of the population and up to 47% of routine cerebral MR imaging. So you might say, why not anticoagulate everyone? Patients with Eisenmenger syndrome have high bleeding risk related to alterations in the coagulation system that include low factor 2, 5, 7, 9, 10, and von Willebrand levels, along with increased fibrinolytic activity and platelet function abnormalities. Although spontaneous bleeding events are usually minor and self-limiting, recurrent hemoptysis is common and attributable to intrapulmonary hemorrhage related to erosion of a dilated bronchial artery, usually at the time of a low respiratory chest infection. For select patients, those with prior thromboembolic episodes or those with evidence of pulmonary arterial thrombosis who have not previously experienced a major bleeding event, defined as a bleeding event that led to a drop in hemoglobin of more than 2 or transfusion of more than 2 red blood cell units, anticoagulation may be reasonable. For patients with atrial fibrillation or any type of atrial flutter, risk stratification for systemic embolism using accepted methods such as CHAS-VASc is not applicable. Anticoagulation should be considered on an individual basis. So don't routinely anticoagulate, but consider it in highly selected patients with aforementioned high-risk features and low bleeding risk. The 2025 guideline also includes a new Class 3 harm recommendation. In adults with Eisenmenger syndrome, closure of any intracardiac or vascular shunt should not be performed given the increased perioperative risk and the risk for short-term and long-term morbidity and mortality. Class 3 harm. The 2018 guideline did not give a specific graded recommendation about shunt closure in Eisenmenger syndrome, although the concept was well understood at the time. Why is this bad? Closure, I mean. Once significant pulmonary vascular disease develops and the shunt becomes bidirectional, defect closure should be avoided because the defect serves as a pop-off mechanism that assists the right ventricle in coping with the elevated afterload. Transcatheter or surgical closure of these defects carries significant peri-procedural risks, and it is likely to exacerbate RV strain and increase morbidity and mortality. This is an important recommendation to formalize, as there may be temptation with the extended capacities of transcatheter closure techniques to consider closing residual defects. This recommendation makes it clear that such interventions are contraindicated. Finally, the 2025 guideline includes another new Class 3 harm recommendation for Eisenmenger syndrome patients. In adults with Eisenmenger syndrome and intracardiac shunts who meet indications for permanent pacing or an ICD, endocardial leads may be potentially harmful given the increased risk for systemic thromboembolism, Class 3 harm. What's the concern? In the presence of intracardiac shunts and bidirectional flow, transvenous leads of a permanent pacemaker or ICD incur increased risk for systemic thromboembolism. So, alternative approaches such as epicardial lead placement or subcutaneous ICD should be considered on an individual basis. Given the low pressurized flow in the pulmonic atrium compared with ventricular flow, the concern for thrombus formation is higher for atrial leads. Some case reports for Eisenmenger syndrome describe successful ventricular leadless pacemaker implantation with short-term anticoagulation until endothelialization occurs, which also may be considered in select cases in highly specialized centers. The 2018 guideline did not include any formal graded recommendations about cyanosis management. There was a table in the supporting text with general guidance, but not graded explicit recommendation statements. The 2025 guideline now provides 10 specific graded recommendations that formalize best practices for managing cyanosis. To briefly review the pathophysiology, cyanotic heart disease is characterized by hypoxemia and central cyanosis caused by right to left shunting. This chronic hypoxemia triggers an increase in red blood cell mass, secondary erythrocytosis, which is actually a normal physiological response aimed at achieving and maintaining optimal hemoglobin and hematocrit to improve oxygen delivery. However, this increased red cell production depletes bone marrow iron stores, leading to iron deficiency anemia. The iron deficiency then compromises systemic oxygen transport, manifesting clinically as exercise intolerance, transient ischemic attacks, stroke, and myocardial ischemia. Additionally, patients can develop hyperviscosity symptoms when hematocrit gets high, typically above 65%, presenting with headaches and visual disturbances. Cyanosis also alters the coagulation cascade, leading to both hypo and hypercoagulability, which increases risk for both bleeding, hemoptysis and epistaxis, and thrombosis, stroke and pulmonary embolism. Chronic cyanosis affects multiple organ systems and can cause kidney dysfunction, hypertrophic osteoarthropathy, myocardial dysfunction, neurologic dysfunction, and even hypertensive emergencies due to neuroendocrine tumors. So this is truly a multi-system disease that requires comprehensive surveillance. This will provide the basis of the subsequent recommendations. The first recommendation is a Class 1 statement. Patients with ACHD and cyanosis should receive annual screening for and treatment of iron deficiency to improve exercise capacity and functional status. Patients should undergo routine screening for iron deficiency even when hematocrit levels are either normal or elevated. The second Class 1 recommendation addresses neurologic emergencies. In patients with ACHD and cyanosis who present with persistent, new, or worsening neurologic deficits, urgent brain imaging to exclude cerebral abscess or stroke should be performed. The third Class 1 recommendation states, in patients with ACHD and cyanosis who present with symptoms of hyperviscosity, rehydration with oral or IV fluids should be performed to improve symptoms and reduce the risk for vascular complications. Most affected patients respond well to rehydration with oral or intravenous fluid and to treatment of the iron deficiency anemia, so there's no need to jump straight to phlebotomy. The guideline includes two Class 1 recommendations about pregnancy in patients with cyanosis. The first states, pregnant patients with ACHD and cyanosis should be closely followed for the entire duration of the pregnancy by a multidisciplinary cardio-obstetrics team of experts in maternal fetal medicine, ACHD, and obstetric anesthesia to reduce the risk for pregnancy-related cardiovascular and obstetric complications. That part is a given. The second states that patients with ACHD and cyanosis who are of childbearing age should receive comprehensive family planning consultation, including recommendations on safe and reliable contraceptive methods from a multidisciplinary team of experts in family planning and ACHD. Multidisciplinary care during and after pregnancy in this population, excluding patients with Eisenmenger syndrome who should definitely avoid pregnancy entirely, has been associated with lower risk for cardiovascular complications compared to those who do not. So while pregnancy is high risk, it's not necessarily prohibitive with appropriate expert care. Regarding contraception, certain methods should be avoided. Specifically, estrogen-containing oral contraceptive pills are associated with increased risk for venous and arterial thromboembolic complications and should be avoided in patients with ACHD and cyanosis. The guideline includes two Class 2A recommendations about uncommon but important complications. First, in patients with ACHD and cyanosis who experience recurrent unexplained hypertension or tachycardia, evaluation to detect pheochromocytomas and paragangliomas is reasonable. Class 2A recommendation. These are rare neuroendocrine tumors that produce excess catecholamines, resulting in episodic tachycardia or hypertension. A higher prevalence of these tumors has been observed in patients with ACHD and cyanosis, presumably related to chronic hypoxemia-induced proliferation of chromaffin cells. The initial workup would involve plasma fractionated metanephrines and 24-hour urinary fractionated metanephrines. Second, in patients with ACHD, cyanosis, and recurrent episodes of joint pain, it is reasonable to check serum uric acid levels and evaluate for gout. Hyperuricemia is common in ACHD patients with cyanosis, so gout should be on the differential for patients presenting with joint pain. There is a Class 2B recommendation that may be helpful for some patients. In patients with ACHD and cyanosis, the use of supplemental oxygen during exercise may be considered to improve exercise capacity. The evidence shows that patients with ACHD and cyanosis have reduced exercise capacity, but the use of supplemental oxygen during exercise is associated with improved exercise capacity compared with ambient air. Finally, let's address phlebotomy in cyanosis. The Class 2B recommendation states, in patients with ACHD, hematocrit more than 65%, and hyperviscosity symptoms that persist despite adequate rehydration and treatment of iron deficiency, phlebotomy may be considered. Phlebotomy involves removal of 250 to 500 milliliters of blood generally, with concurrent volume replacement of 250 to 500 milliliters of isotonic fluid. It may be considered in patients with refractory symptoms of hyperviscosity syndrome after adequate hydration and correction of iron deficiency. But here's what you should not do, and this is formalized as a Class 3 no benefit recommendation. In patients with ACHD and cyanosis, prophylactic phlebotomy is not recommended. In other words, routine phlebotomy in asymptomatic patients just because their hematocrit is high should be avoided because it exacerbates iron deficiency and increases stroke risk. We've now gone over 6 major areas of update in the 2025 guideline, including pregnancy and delivery, atrial septal defect closure, Fontan screening, pulmonary valve replacement and tetralogy of Fallot, Eisenmenger syndrome, and management of cyanosis. There are a few other areas that I also want to cover that may be less practice changing for day-to-day management of specific conditions, but are still important to know, including heart failure GDMT in ACHD, sports participation, rhythm control, and personnel and expertise. Heart failure guideline-directed medical therapy, or GDMT, in ACHD is a new topic in the 2025 guideline that was not included in the 2018 guideline. There are 3 new recommendations about GDMT in heart failure. In patients with ACHD and left heart failure symptoms who have systemic left ventricular dysfunction and biventricular circulation, and who otherwise meet accepted criteria for cardiac resynchronization therapy, use of CRT is reasonable to improve heart failure symptoms, Class 2A. Second, in patients with ACHD and heart failure symptoms who have systemic LV systolic dysfunction and biventricular circulation, use of GDMT for heart failure is reasonable to improve heart failure symptoms, Class 2A. Third, in patients with ACHD and heart failure symptoms who have systemic LV dysfunction and biventricular circulation, who otherwise meet accepted criteria, use of a primary prevention implantable cardioverter defibrillator, ICD, is reasonable to prevent sudden cardiac death, Class 2A. Randomized clinical trials show that GDMT, CRT, and ICDs improve outcomes in heart failure, but most of those trials excluded patients with ACHD. So some amount of expert consensus and extrapolation was needed in formulation of these statements. The evidence for GDMT in patients with ACHD and biventricular circulation with systemic LV systolic dysfunction is mostly limited to retrospective studies. Newer therapies such as angiotensin receptor neprilysin inhibitors, or ARNIs, or SGLT2 inhibitors appear to be well tolerated and safe. In retrospective studies, the use of these agents is associated with reduced heart failure hospitalizations as well as improved New York Heart Association functional class, biomarkers, and LV function. For patients with a systemic right ventricle, such as those with detransposition after atrial switch or congenitally corrected transposition, the evidence is much more limited compared to those with a systemic left ventricle. The guideline notes that the wide anatomic and physiological variation in ACHD means that the benefits and harms from GDMT likely differ from those in patients without ACHD. For example, some patients with ACHD may be predisposed to bradyarrhythmia or endocarditis, which could counterbalance the benefits of beta blockers or ICDs or CRTs, respectively. Therefore, both the strength of recommendation and the level of evidence of use of GDMT device therapy in patients with ACHD and heart failure are lower compared to those without. Next, there has been a shift in how people think about physical activity in ACHD patients. The 2018 guideline did not include a formal graded recommendation specifically about competitive sports participation. The 2025 guideline now includes a new Class 2A recommendation. In patients with ACHD, participation in competitive sports is reasonable following a comprehensive evaluation by an ACHD specialist that incorporates functional status and individualized assessment of risk and benefits. Guidelines for physical activity in patients with ACHD have shifted away from a historical focus on restriction to emphasizing promotion of activity and sports participation, given the many increasingly documented health benefits, including improved functional capacity, vascular and autonomic function, and patient-reported outcomes. Most patients with ACHD can safely engage in regular, moderate physical activity and should be encouraged to engage in recreational exercise or appropriate physical activity. There are a few conditions that do warrant more cautious recommendations, such as systemic ventricular systolic dysfunction, systemic ventricular outflow tract obstruction, hemodynamically significant arrhythmias, or aortic dilation. But the overall philosophy has shifted toward enabling participation rather than blanket restriction. The 2025 guideline includes specific recommendations about rhythm control versus rate control strategies in complex ACHD patients, particularly those with systemic right ventricles or Fontan circulation. For patients with DTGA or detransposition after atrial switch, the 2018 guidelines noted that sustained intra-atrial reentrant tachycardia is a potential cause of sudden cardiac death in adults who have undergone atrial switch and puts patients at risk for thromboembolism, and noted that efforts to maintain sinus rhythm or atrial pacing, and not simply rate control, should be the initial strategy of management. However, that was stated in a supportive text rather than as a formal graded recommendation. The 2025 guideline has now made this a formal Class 1 recommendation. In adults with DTGA and atrial switch who have atrial arrhythmias, rhythm control strategies are preferable to rate control strategies to reduce symptoms and prevent heart failure. That's a Class 1 recommendation. There is a biologically plausible explanation for preferring rhythm control in these patients, including longer atrial tachycardia cycle lengths in the context of extensive atrial sutures or scar that could favor rapid one-to-one ventricular conduction, a reduction in stroke volume with faster heart rates attributable to poor atrial transport, and myocardial ischemia despite the absence of coronary artery disease attributable to an inefficient coronary circulation supplying the systemic ventricle. Similarly, for Fontan patients, the 2025 guideline emphasizes the importance of prompt management of atrial arrhythmias with rhythm control. Atrial arrhythmias occur in more than 60% of adults with Fontan circulation and are a significant source of morbidity and mortality. However, even though the guideline writer's top take-home message number 7 is rhythm control is typically preferred over rate control for atrial arrhythmias in complex patients, such as those with a systemic right ventricular or Fontan circulation, they did not write this out as an explicit recommendation statement in the Fontan section. So I'm not sure if they forgot or if they intentionally left it out. The 2025 guideline has significantly expanded and formalized recommendations about who should provide care for patients with ACHD and when specialist expertise is required. The 2018 guideline had 2 broad recommendations in this area, but we now have much more specific recommendations here. First, regarding ACHD programs and cardiologists, there is a new Class 1 recommendation. Patients in adult congenital heart disease anatomic physiological Class 1A should have at least one evaluation by an ACHD cardiologist to develop a plan of care, Class 1 recommendation. Second, for non-cardiac surgery, the 2025 guideline adds a new Class 1 recommendations. In patients with AP classifications 1C to D, 2B to D, and 3A to D who undergo non-cardiac procedures, post-procedural care should involve collaboration with an ACC cardiologist to incorporate expert opinion, provide guideline-based medical therapy, and improve outcomes. Additionally, in patients with AP classifications 1C to D, 2C to D, and 3A to D, anesthesia for non-cardiac procedures should be administered by or in collaboration or consultation with an anesthesiologist with ACHD expertise to reduce the likelihood of perioperative complications. Next, for cardiac surgery and invasive cardiac procedures, the 2025 guideline adds new Class 1 recommendations. In patients with classifications 1C to D, 2A to D, and 3A to D, anesthesia for invasive cardiac procedures should be administered by or in collaboration with an anesthesiologist who has congenital heart disease expertise to reduce the likelihood of perioperative complications. So pretty much the same as the prior recommendation for the non-cardiac surgeries. They also say in patients with ACHD undergoing invasive cardiac procedures, post-procedural care should involve collaboration with an ACHD cardiologist to incorporate expert opinion, provide guideline-based therapy, and improve outcomes. In patients with ACHD who undergo invasive cardiac procedures for acquired cardiovascular disease, it can be beneficial for operators with expertise in procedural treatment of acquired disease to collaborate with ACHD experts. This is another new Class 2A recommendation. That covers everything about the personal expertise, rhythm control, sports participation, and heart failure GDMT that is newly updated. Now that we've gone over these major and minor update areas, I want to highlight that the 2025 guideline writers offer 10 take-home messages that they want us to know about. 1. Adults with congenital heart disease benefit from routine care at adult congenital heart disease centers and in collaboration with ACHD cardiologists. Multidisciplinary teams are useful for complex care decision-making. 2. Patients with anatomic or physiologically moderate or complex ACHD who undergo cardiac or non-cardiac procedures are recommended to have an ACHD cardiologist involved in their care to offer expert guidance on procedures, anesthesia, and post-procedural management. 3. The possibility of endocarditis is important to evaluate in acute or subacute malfunction of bioprosthetic pulmonary valves, and endocarditis has been added to the physiological classification system. Subacute bacterial endocarditis in the past year is stage D. 4. Most pregnant patients in ACHD can undergo vaginal delivery safely with appropriate risk stratification and monitoring. 5. Updated recommendations for tetralogy of Fallot include A. Referral for pulmonary valve replacement in patients with repaired tetralogy of Fallot according to right ventricular end-systolic volume criteria of more than 80 milliliters per meter square and other metrics rather than end-diastolic volume. And B. New approaches to arrhythmia management including ablation of ventricular tachycardia. 6. Strategies for patients with secundum atrial septal defect and pulmonary arterial hypertension now include recommendations for closure for many patients with a significant left-to-right shunt and pulmonary vascular resistance of 2 or less Wood units or between 2 and 5 Wood units. 7. Rhythm control is typically preferred over rate control for atrial arrhythmias in complex patients, such as those with a systemic right ventricle or Fontan circulation. 8. New recommendations on guideline-directed medical therapy for heart failure in patients with ACHD include people with a systemic right or left ventricle and discussions of pacing strategies for a systemic right ventricle and Fontan circulation. 9. Patients with Eisenmenger syndrome can be treated with pulmonary vasodilators using either phosphodiesterase 5 inhibitors or endothelin receptor antagonists as initial therapy. 10. Fontan screening for liver disease includes recommendations for at least annual imaging and laboratory evaluation, including alpha-fetoprotein and at least one consultation with a hepatologist. Okay, we've covered a lot today in under an hour. I hope you found this granular comparison insightful and efficient. I encourage anyone who has time to check out the full guideline at the ACC and AHA guideline hubs. Thank you for joining me on a deep dive of this guideline. Please check out the other deep dives of guidelines that are available on my channel. Until next time.